Okay, hi everyone. We're about to get started. It's just going to be Dr. Williams today again. One question, one follow-up, and we'll stick to half an hour. I'll turn it over to Dr. Williams.
All right, thank you. Good afternoon. And yes, I'm here. Dr. Yaffe is doing another call, so it's either she did the call or I did the call. So I'm here today, and I'll be doing both the numbers and answering questions in that regard. So as we said yesterday, the focus is on long-term care. Our different things were rolling out fairly quickly in that regard. A number of aspects. You heard from the Minister of Long-Term Care, Mr. Elliott, and the Premier today talking further about some of the steps that were being undertaken through emergency orders and other things to support in our response, I should say responses to the long-term care issue that, as I said, not only we are dealing with, but on a pan-Canadian basis, all of the provinces are dealing with and seeking to come up with more definitive answers and solutions to this ongoing problem and crisis that, of course, is unfortunate when we have a number of individuals in that state of life passing on if it's due to COVID-19, and trying to ascertain how that had contributed to it and what we could do with those situations to prevent it even further. So with that, I'm going to talk about the numbers, and this is where I'm going to be going back and forth with a few aspects there because people have had a number of questions on that. So right now, the total for Ontario of positive cases reported through the Integrated Public Health Information System is 8,961. That represents an increase of 514 confirmed cases over yesterday's report. And I'm going to talk about that in a moment here. Still, our trend is that there's more females than males in there, and we're beyond 10%. We're up to about 13% difference in there. And that continues to be different than some of the other data across Canada. And so we're asking our folks in the data section, what is the difference between that? Is it mostly due to our demographics in our institutions, or are there other reasons that we need to assess? At the same time, nearly 42% of our cases are 60 years of age and older, and the Greater Toronto Area still accounts for about 55% of the cases overall. We reported 423 deaths. 38 of those is an increase from yesterday, and 29 of those were related to long-term care. We have 104 outbreaks that have been reported in long-term care, and with the numbers that have been reported total there of 163 up till now. And so those 104 outbreaks, some are resolving, some are being investigated, and as I said before, we have set the bar low, so they're calling outbreaks as soon as they have one person symptomatic, and that starts the whole outbreak management process moving into high gear to assess, rule in, rule out as quick as possible, with a lot of extra testing being undertaken in that regard. Our number of healthcare workers, the cumulative total, which is 980, which is the long total now, and we're trying to work at how to get our healthcare worker numbers a bit more segmented on that. That's an cumulative number, so that's that up to date. We have in our hospital now 12 increase of 807 patients currently in the hospital. That's an increase of 12. Our ones in ICU have decreased by 6 to 248, but the ones in the ICU on a ventilator increased by 12. And I said before, often the ICU, the ones going on and off can vary quite quickly as the day goes on. So I would say these numbers are more of a plateauing effect in the ICU rather than a distinct drop. And while it may be encouraging, I wouldn't make too many assumptions on that at this time. But the main thing is, as compared to our modeling data, it is not going up and doubling every few days. So in the laboratory testing, as we said, we now have done 128,093 tests, and we have currently 4,323 under investigation. Now, that may seem like a backlog, but that was in the past when we had it in one lab in PHOL. This is in all the labs, which basically is how many in the queue for being processed that day. So we don't call that a backlog. We call the ones that have been queued up ready to go. So in the last 24 hours, we have completed over 9,000 tests, which means we did reach the mark of the 8,000 that we and the Premier had promised to get to by today or yesterday. So we did that because these are the tests were done yesterday. So back to the 514. And as I noted yesterday, when we looked at that, we were seeing that since the end of the long weekend, we started seeing more and more of the cases being related to long-term care, more and more tests being done in long-term care, and because we'd already started ramping up with our decreased criteria for testing, our testing in around wider cases that even asymptomatic patients or residents around the case would be tested, and staff as well, even if they were asymptomatic. So that number has been increasing. So of that 541, 271 were related to long-term care. That means there was 243 in the community side. So this is the first time we've seen more in the long-term care than in the community side in that. That's more of an artifact of the testing and what we're doing in that number, but also the fact that we're continuing to see the use on the community side dropping. Our travel related ones are pretty well gone. With the social distancing, the physical distancing is making an impact with bending the curve. And as I said, we're hoping to hear from our modelers on the report. How are we doing? How have we done? And are we going to continue to make direction that way? And if we are, and doing that, how are we going to look at saying if we're going to ease off some of our public health measures, what would we, when would we, and how would we dial it back, if you may, to get to that number at that time? So I think the encouraging part is that there's less, we're down under the 300 level on the community side. The other side is on the long-term care. We really ramped up the amount of testing, and we know that some of our MOHs, our medical officer of health, and local public health units were asked to undertake to do some of their institutions on a full scale of doing all the residents and all the staff from a spot check, like a spotlight, to say at this one time, what did it look like? And is the demographics and the layout of cases as we anticipated or different? And we should do it in different regions because the province is not being impacted equally throughout the whole area homogenetically, but it is variable. And so if we pick a sample in areas where it's very little activity, we might get a false conclusion that things are not very important or very small and it's not a big issue. So we need a wide range of surveillance data to do that. And now that we have the capacity, we can undertake that task because we're not talking about an inconsequential amount of tests. We're talking about quite a few tests to undertake to even do that survey and still do our outbreak management and still do our priority groups and the other ones we need to deal with, including our healthcare workers, our First Nation Indigenous populations, as well as our other conjugal settings where there's outbreaks and cases there in that regard. So we still have to deliver on all those others while we undertake to do these enhanced investigations at this time. So, so we have the data, we have the information there, and with that, I'm going to open up for questions.
Okay, we'll move to the first caller, please.
Which will be Kenyon Wallace at Toronto Star.
Good afternoon, Dr. Williams. I am just wondering, in terms of the emergency order that was enacted yesterday to prevent personal support workers and others from moving between different long-term care facilities, why are we enacting that, or putting it into effect, I should say, on April the 22nd rather than now? Epidemiologists I've spoken to have said that if we really want to stop the chains of transmission between long-term care facilities, we should be doing this as soon as possible and not in a week. So where does the logic come for doing this on April the 22nd?
Right. So I think I was asked this question yesterday. So again, let's see if I can say exactly the same. When we started off in this process, one of my recommendations originally was that we try to decrease the amount of movement of these part-time people between the various institutions, and because we had experienced some problems with that in SARS and also in the pandemic or the influenza back in a number of years ago. So that recommendation, we carried forward guidance documents and asked that people who are in multiple sites would notify their employer, and they would then, if there was an outbreak in their institution, the one they're in, and they're isolated, they'd have to cease from working in all the other sites if they're in more than one or two sites in that regard. And so we continue to say that is our direction. During that time, there was a number of steps taken to look at all the reasons and methods to get to that, and the only venue that the ministry and the cabinet could come to was use an emergency order because of the various aspects related to labor law and various agreements and aspects therein that makes it necessary to do that and to look at all those aspects in there. Once they have got the order in place, then to implement that order, one has to go through a number of steps, because if you just flip it quickly, you may end up losing a half or third of the staff in institution, and then you end up with residents not getting any care. So one wants to do it by bringing in, as they've noted, and the ministers noted, with some other staff resources, either from the healthcare sector or from our volunteer group or from students to come in at that time to make sure that in the outbreak management, in the case of this implementation of this order, one does not decrease the workforce and compromise the outbreak response or the ongoing necessary care of these residents, as we have seen in some other settings that was, in our minds, not at all acceptable. So while I understand there seems to be a delay, I would say to get to that point, to do it carefully so you don't cause disruption and loss of care for these elderly and frail individuals.
Follow up?
Yes, and in terms of the daily testing numbers that we get shown every morning around 10:30, as of yesterday, the province began to present those testing numbers as samples tested rather than patients tested. And my question is, what was the thinking behind that change, and how does that then help us if, up till now, we've been looking at the number of patients tested, whereas a single patient could get, like you say, 2 or 3 tests. By presenting it as samples, doesn't that prevent us from knowing how many people were actually tested?
Right. And all along in the past, before we went over to the system, we had reported that we did so many individuals were tested, but we said also that they said, well, how come the public health laboratory only did this many? And said, well, they actually did more tests, but they had to do multiple samples on people admitted to hospital. A person may get tested in the emergency department, then they get in the ICU. They may do 3 or 4 samples. That's just part of the protocol. Those tests still have to be done. And because the question was, well, how come you're not doing more and more tests? What's wrong? Why can't you keep up with the rest of the country? And that kind of thing there. So a lot of the questions say you have to increase the number of tests you're doing. So as a result, we have this system now where you can say, here's how many tests we are now putting through our enhanced laboratory system. 9,000 is the premier promise to get up to 8,000 yesterday and going up to 13,000 in the future. So the point you're raising is, how does that get translated into patient data? And that's where we have our public health information system integrated. And we have to then take those data, make sure they're matched properly, because you may get some people double or triple counted. And then you have to link them into what their exposure issue is and do all that investigation, and then enter the comprehensive data into the IFAS system. And that is not as rapidly available as the sample data, which is, of course, what a number of people from the media were asking for. So we're going to try and do those things both ways, but for our purposes, one tells you how does the system, the enhanced laboratory system, how is its performance doing? That's the data you're getting now. And then from the epidemiological data, how does the IFAS data match with that, knowing it's going to be not the same number because there may be people multiple counted, and you have to make sure you clean the data up in that regard and enter it accurately. And that does take time and period to do so, and therefore it won't be as up to date as the amount of samples done.
Next question.
From Christopher Herhart at CP24.
Good afternoon, Dr. Williams. I've been speaking with a person in Halton region who's been waiting for the results of her COVID-19 test for 20 days. She's been told not only to keep waiting, but that there are plenty of others who have waited just as long. Is this acceptable, and how does a wait this long impact contact tracing and data collection efforts at your level?
Well, we've had others that we were told about, and when we check back on it, first of all, it's not acceptable. We are reporting to turn the test results around in 48 hours. And the aspect is when the sample goes into now not just one lab, but number of labs. Each one of those labs are required to do 2 things. One, if it's a positive, report it to the local health department. If it's negative, they don't tell the health department. They report it to the physician who requested the test, or the assessment center, or the doctor who's in the assessment center that day, who requested the test. Then when you send the results back, it goes back to that doctor, and that doctor is not there that day or is on quarantine for 14 days. It may sit in their file. So we have to address these system issues to say, so what happened with the communication here, and how come it wasn't handled better? So in the busyness and all these different sites, we had some others that they said, well, we went and we didn't get it. And they said, well, we checked back, and actually you went to the other site and went to this one, and so there's some confusion on where the site was taken. So I'm not trying to make excuses. I would say 20 days is way too long. Even 10 days, 7 days is too long. And we need to address those system problems if there is a lack of communication as you get more labs on board, more assessment sites on board, and more sites and physicians and other centers on board. There is sometimes miscues on communication and the data sharing. So it's not acceptable, and it's something we have to be alerted to. So thank you for making us aware of that, and we'll continue to try to address those. Unfortunately, so far, they're not the common part, but it doesn't mean they're acceptable.
Follow up?
On Tuesday, Health Minister Christine Elliott said, quote, only recently that we learned you can be asymptomatic and still transmit the virus, end quote. When exactly did the concept of asymptomatic transmission become accepted by your command table, and why has it taken so long for Ontario to accept this concept when it has been documented in studies written in English in several peer jurisdictions such as South Korea, Iceland, Italy, and Taiwan?
So the questions that we've been bringing back to our Federal Provincial Territorial Committee on that and reviewing the data. And what you have to understand is that when they're saying they will find people who are asymptomatic, pre-symptomatic, posse-symptomatic, that's a fancy term, that when they're testing someone with a test, the so-called polymerase chain reaction test, it picks up fragments of the RNA. That doesn't mean that they're actually live virus or not. It doesn't mean that they're actually transmitting or not. And it doesn't mean they've had a so-called viremia or an infection or not. That's one of the limitations of the testing. When it's very sensitive, it can pick that up for a long period of time. So the question is, when we found that when they did a study, the ones that said they had asymptomatic transmission, they found asymptomatic people were positive. When they interviewed the people, they said 75% said, well, okay, in the last 14 days, I guess there's a couple of days I did feel off, now that you mention it. So what is asymptomatic, and what do people recall? It's hard to remember what it was the last 2 or 3 days, let alone 10 days ago. So we asked that question, and if you do find it, if it's dead virus, are you actually transmitting? And that actual thing of doing viral cultures lifetime, they're not doing that because they can't right at the moment. And so we're continuing to be informed by that ongoing investigative science to say, what is it? Just because you find it, does that mean the person's transmitting or not? Because the test tells you one thing, but the transmissibility is another thing. So I'm not trying to make the science sound confusing. It is evolving because we didn't have this organism before the end of December, early January. So the science has evolved very rapidly, and we want to keep being informed by the science with more investigations, including serology and other new tests coming forward, and hopefully getting a sense of some live viral testing in that regard. So right now, our position with the Federal Provincial Territorial is that because people's history taking, you have to assume that some can be asymptomatic and still have a positive PCR test in there. That doesn't say they're automatically transmitting, but the potential for transmitting is definitely there. So we're being extra cautious and saying, let's assume they might be and go back to that. That's only been in about a week ago, about 9 days ago, when we came to that conclusion at the FPT table.
Next question.
From Cynthia Mulligan at City News.
Hello, doctor. In looking at the hospitalizations, I'm curious. So today we have 807 people in hospital. How many of those 807 come from long-term care? Or are the majority of long-term care patients staying in long-term care? So are our hospitalization numbers actually lower than is actually reflective of the people that need medical care?
Well, thank you. And we're trying to ascertain how many patients are being transferred on a regular basis from long-term care over to the hospital in that regard. We haven't segmented that data out. Our information is not a lot of them are doing that in there because, remember, a lot of these people are in stage, but we're trying to ascertain if someone has a COVID-19 infection and has an acute, let's say, deterioration in their situation, and they don't already have some life plan action in place that's personalized and what the family has agreed to, then the physician who looks after that institution can authorize the transfer from the long-term care facility to the acute care facility for a diagnostic workup, because the long-term care facility doesn't have like the x-ray, CT scans, all the other ones that they would endeavor or want to have to assess if this individual's condition was nothing to do with their reason they're in long-term care, and was more an acute exacerbation, if you may, and could be remediated if possible, and it wasn't contravening the wishes of the family or the patient in that regard. So we're trying to assess and follow that, and to see if there's a lot of transfers or not. Right now we haven't been made aware of a lot of transfers.
Follow up?
No, that's okay. I'll let somebody else have a chance. Thank you.
Next question.
From Rob Ferguson, Toronto Star. Please go ahead.
Oh, hi, Doctor. I'm just wondering, earlier this week you were saying that it looked like we might be hitting the peak this week, but I seem to notice a bit of a pullback from you on that today, and also in particular from Minister Elliott, who said they're still, I forget her quote, but she basically said we're still waiting to see which way this is going to break. So has anything changed in that regard?
So I would say from the different ones we watch about with the modelers, they look at cases, they look at ICU admissions, and they look at deaths, and to see if there are any trends and directions. What we've seen is that for the last number of days, the ICU admissions, the hospitalized, the ventilators and the aspects there, and deaths, the deaths have accumulated and gone up, not as fast a pace as anticipated. The ICU and other ones have remained fairly level, which is what they said they might predict in this week of April or next week. And so there's a sense is that has that plateaued. At the same time, when I said earlier at the start, when I was anticipating after the extra long weekend we just had, which was after the 14 days of the main travel inflow, and our travel cases had really dropped off, I would assume that our cases would be dropping down from the 500s to the 400s to the 300s and so forth. I was a bit surprised when they stayed up in the mid to upper 400s, but then when I went back and did some further dissection of that data, I can see what's happened since the beginning of April, about the 8th and 9th of April on. We had already started our ramping up of getting our health units to do a lot more testing in long-term care facilities, so they are contributing more and more, whereas in the past they had a small contribution. So like the numbers I said today, the 514 cases in there, 271 related to our outbreaks in the long-term care facilities. This is the first time that those have actually been more than the community cases, which now have dropped down to 243. So in that sense, I was saying I may be optimistic in that, because in the past we had well over 400 community alone, and we had peaked around 550 and very few from long-term care back about 2 weeks ago. So maybe, in fact, after this long weekend, we are coming down, and I'm asking our data people and others to segment the data so we can get a correct amount to our modelers to say on the case counts also, are we coming down? Because you have to compare trends with apples to apples. So we've changed the thing by adding a whole bunch of new things in with our enhanced testing and surveillance in the long-term care homes. So you got to make sure we separate it out so we're still comparing to what we have today with the same things we were comparing with 2 weeks ago.
Follow up?
All right, sorry, I had to take it off the speaker there. And I'm wondering, at this point, are you pretty confident that, sorry, let me change gears on that. At this point, I think you were saying this morning, or earlier in this news conference, about 2/3 of the new deaths were all in long-term care?
Today that's the case. Yesterday was a bit more on the other side because it varies on how they come through. So yesterday we had a lot more deaths, 51 I believe, and a smaller percent of those were from long-term care. Probably some other ones were from the hospital sector. And so it doesn't happen equally all the time. It has its ebbs and flows.
Next question.
From Phil Perkins.
Data collection isn't what they have the time for, but we're going to try and facilitate that so we don't overload them in that regard and see if we can get the answer back to you.
Okay, next question.
From Émilie Pelletier, Le Droit.
Hi, doctor. I wanted to talk about the gap between men and women. I know you said that no studies have shown that women are more prone to catch the virus, but we know that a lot of healthcare workers have contracted the virus. And I was wondering if there would be a possibility that this gap could be explained by the fact that a lot of them, I'm thinking nurses, are women.
Good point. As I said, on the national data, especially as far as the severe consequences, the males dominate over the females. So we have that sort of different picture there. So we're trying to understand, is Ontario unique than others? I think the idea you said about the female side being the more dominant in demographic in the workforce in the healthcare, I think that would be definitely true. So it's an aspect we could put in the mix on that one there. The numbers in the overall big numbers it contributes. I wouldn't say it gives us a total picture, but it certainly could add to it. The other aspect we found is that a lot of our individuals in the long-term care facility and even those living out in the community over the age of 70, let's say, there tends to be a predominance more of females than males just because the life expectancy is longer in the females than the males. But we keep asking our epidemiologists to say, as this continues to widen from 8% to 10% to 13%, just like you're trying to do, what is the answer for that? So we're still looking. Thanks for that idea.
Follow-up?
I don't have a follow-up. Thank you.
Okay, we'll move to the next question, and that'll be the last.
From Stephanie Smythe at CP24.
Good afternoon, Doctor. We know that there have been new measures in place with funeral directors not to go into long-term care homes where, sadly, some of the residents have died. We understand now that it's been put to the PSWs, the personal support workers, to deal with the remains of those who have passed away in those homes due to COVID-19. Do you think that this is an appropriate use of the PSW? Is this approach at all appropriate? And how are we expected to maintain the workers, the PSWs in those homes if they know that this is going to be part of their duties now?
Well, I haven't given any specific guidance out in particular. They may have rules in their own institutions of what they're doing in that regard. We've just had some federal ones tabled in that regard, and I know our chief coroner has had some further directions around coronial services in relationship to COVID-19 as well. So I think as we go through this process of looking at our human health resources in our long-term care facilities, whether in the midst of an outbreak, in that and the best utilization of staff and timing, these are issues that we will be addressing. If they're looking for a different direction, I will take that advice from Ministry of Long-Term Care as well as from Ontario Health and others. If there's a need to be more specific guidance and direction from the province, then we would undertake to do that. So as of yet, I haven't given any specific direction in that regard, and that's been left up to the local institutions and the local areas to decide that on their own volition.
Okay, follow-up, and this is the last question.
Okay, I want to ask you about false negatives. And last week, Dr. Yaffe stated that the swabs are quite accurate, about 90%. But this isn't what is being widely reported around the world. We're hearing from nurses with the ONA that patients who are tested are potentially receiving false negative results and then are being sent home or cleared from any isolation but could be carrying the virus. Some of them are later re-swabbed and getting a positive result. What are we to make of this?
Well, that substantiates what we've been saying before, is that people say, well, why don't you do broad testing and test people so that they can be reassured they're negative? If you do something that's negative, it tells you that at that moment they're negative. They actually may have small viral particles you didn't pick up. They could be incubating, which means they could be negative today and then positive 2 days later. Was that a false test, or was it just they missed it and it was still not yet enough growth to show positivity? So a negative tells you negative at that moment. It doesn't mean you're going to stay negative always. And so that's why we don't put a lot of value in a negative test. in that sense, except to say if we're having someone being cleared who was already positive and now they've converted to negative and they returned either to out of isolation, it's resolution, or it's a healthcare worker who's going back onto the ward or other essential worker in that situation there because they know they were positive and now they're negative. But a negative test, and that's why we have discouraged in general, just saying if you just do a negative, then does that mean the worker is fine for the next week or 2 weeks? Not at all. I mean, you have to keep assessing to see if they develop symptoms and signs. So I think you have to be careful what you're assuming is a false negative rather than a test that was repeated and became positive in that regard. And we look to our medical microbiologists, our experts, to say on your testing, whether it's, I don't get too technical here, remember we had the 1 allele test, went to the 3 allele test, so you have different what they call sensitivities, and and we're trying to get some real detailed analysis from them to say, so what is the sensitivity? Is this one compared to that one? And the number you're quoting, is that correct or not correct? So we keep asking that question, but I think you have to make sure that the false negative isn't actually a serial timing difference in testing.
Okay, thank you, everyone.